we're almost there. Fractures around the knee, tibial plateau fractures, obviously very uncomfortable. So the way that you would look at these, and the biggest teaching point I have for this, we'll go through this, but the two things I want you to remember are whenever you are out in practice and somebody shows you this and they say, is this okay? How much, I'll try to do it with this mouse. So when you talk about with tibial plateau fractures, obviously how many pieces, and this one's a bajillion. But what you care about is you care about the step off. So if this is your articular surface right here, how many millimeters can you accept medially and how much can you accept laterally? Now if you guys know this, I'm going to be thoroughly impressed. Does anybody know how many millimeters you can accept medially? Anybody?
3.
2. 2 millimeters. Now you know what a millimeter is on a ruler? Not very much. The medial side does not accept step off a lot. It does not like it. You will have osteoarthritis, they'll have pain, all this. Now, the lateral tibial plateau, does anybody know how many on that? Yes? 4. Any other guessers?
6.
10 to 15. Seems like a lot, right? That's 1.5 centimeters. And you're thinking, holy crap, the medial goes 2 and the lateral goes 10 to 15. Now, the hard part is explain that to your patient. Whenever their bone looks like this, you go, now trust me, Mrs. Johnson, this is going to be okay. But so it can accept a lot more. Now, will most people let you get away with that? No. But if you're just talking about book answers, it's 10 to 15 that you could literally leave alone and it would be okay. Now, if not, of course, we would go in and do, on this guy, God bless him, you know, ORIFs and all that. But yeah, so 2 millimeters on the medial, 10 to 15, which I would say in real world terms would probably be closer to like 7 to 10 for just people who you show their x-rays to them and they freak out. As they should. Fractures of the tibial condyles just below the knee joint line, generally above. So location, 60% are lateral, so that's nice because the lateral you can get away with not performing surgery with more depression. 15% are medial and 25 are bicondylar. One cool thing is this Willis textbook of orthopedics, I believe it's free online. It is a very, very cool resource because what it does is they have this skeleton, and even if you don't even know what you're looking up, you can put the pointer on the body part and it will start bringing up articles about that. That is a very cool free resource for orthopedics. They bring up journal articles about whatever you're trying to look up, like meniscal repairs and all that. It's actually pretty cool. So that's a little one to tuck away for whenever you're out in practice. Exam rule out compartment syndrome. Everybody knows about compartment syndrome, right? 5 Ps. Yes. Okay. Perineal nerve function. Once again, if you're this dude and your perineal nerve runs right over your fibular head, are you worried about that at all? Right. So make sure they can do a dorsiflexion of their ankle and feel between their first and second toes. Radiographs, once again, AP and lateral x-rays, oblique in comparison to the contralateral side may be helpful. So you would get a CT scan with a coronal and sagittal reformation. That's what you want. So it gives you this really cool looking 3D image. So whenever you're talking about surgery and how am I going to put a plate on this thing, what kind of screws am I going to put on this thing? So it gives you a very, very cool 3D, and you can actually spin these around, and it's pretty interesting. But this gives us a lot of help on what we're up against. Non-management, once again, a non-displaced, minimally displaced with a stable knee examination. So if you do their knee exam and all their ligaments and meniscus and everything feels good, believe me, if their knee looks like that, you're not going to go, now just lay down and I'm going to twist your knee a little bit. They're not going to handle that. But once again, if you can get a good enough knee exam on them to test their ligaments, sometimes if they're non-depressed or minimally depressed, once again, 2 medially, 10 to 15 laterally, then they don't have to do anything. Mobilization with a brace, non-weight bearing, referral, this is from a non-orthopedic standpoint, but referral and then early range of motion. The problem is these things want to get stiff, so you actually have to teach them and or their spouse how that you can move their knee passively without hurting them. Operative, the majority of them are. Displaced wedge, the condylar widening, which is that, so condylar widening. Depression of the articular surface. Preoperative planning, consultation with orthopedic surgeon. Majority are due to direct trauma, either from a fall or a direct blow. So these are the people, the last one that we had like this is one of a girlfriend and her boyfriend got in a fight, and so she was trying to get away from him, so she jumped out the 2nd story and landed on both of her legs. She landed on her feet, which was impressive, but then she ended up with that, which was not as impressive. So you have to be careful with these things. You have to check their neurovascular status. Careful with contractions or forceful contractions of the quadricep muscles. You'd have to have some really big quads to break your leg like that, resulting in the avulsion fracture of the quadriceps tendon and or patellar tendon. So whenever you see these things, your fresh out of school brain just looks at this and goes, oh my gosh, right? You're almost wondering how their leg didn't fall off. But that's where it's very, very easy to start missing stuff. So that's why I said, start at the first of your exam and always stay consistent all the way through. That way you don't overlook something on that. Because if you miss a compartment syndrome or a peroneal tendon or a nerve injury, that's a bad thing, obviously. Severe anterior knee pain, knee held in full extension with little to no range of motion. Large effusion, obviously, and they cannot bear weight on it. This says generally they're never going to put their weight down on that. The radiographs, once again, the CT with coronal and sagittal reformations. And that's how you order it. I need a CT of their knee with a coronal and sagittal reformation, and it'll give you that cool 3D looking thing. The direct trauma, indirect trauma, of course, the indirect trauma would be less comminution than if you fell out of a building or a car or something like that. Any incongruency of the articular surface, so this is talking about the medial, 2 millimeters, greater than 3 separation. So if it's 2 millimeters depressed, but if you have 2 segments that are from a medial to lateral, if there's greater than 3 millimeters between the two, that's the separation, and that also, oh, I'm sorry, this is patella, but it's the same thing on the tibia. You have to fix those. So, any questions on the tibial plateau fractures? I know you guys are getting there. Bear with me here. Fractures of the patella, once again, majority due to direct trauma to the patella. Now these are more, I got hit in the knee with a baseball bat, I got hit in the knee with a baseball. I was going out and fell off my porch and I couldn't get my leg out fast enough, and so they'll fall directly down on the concrete on their kneecap. The presentation, obviously, I think I kind of intermingled those two, but once again, they all kind of go the same. Severe anterior knee pain. They will not want to bend their knee because if they have a transverse patella fracture, their quad has the top part, their patellar tendon has the bottom part. If you bend their knee, it's going to pull those two pieces apart, and they are not going to enjoy that at all. So a lot of times, they will come in from the emergency room. If you're first line, always immobilize them in full extension, automatically right away, because that's going to take all the pressure off of everything. Once again, generally unable to bear weight. I did go over on that, and I apologize for that. CT, we don't do CTs for fractured patellas. X-rays will usually show you everything you need to know, but make sure that you get a sunrise view if the patient will do it. Does everybody know what a sunrise view is? So it's whenever you do it right down, so basically an angle like this, and it looks like their kneecap is coming up over the mountain, so it looks like a sunrise. Because a lot of times, if you can imagine if the fracture is vertical, straight up and down, and you look at it from a lateral, you're not going to see it, because it would be like, so if this is the fracture, and I do this, you can't see that fracture, so that's why you want that sunrise view. So here we go. Sunrise view, you can see that. You cannot see that from the lateral a lot of times. Transverse fracture, so you can imagine once again, if their quad tendon has this piece, their patellar tendon has this piece, and you bend their knee, you can move it like that. And then obviously a comminuted fracture. Most of the ones that we see are non-operative because most of them are non-displaced transverse fractures. Very rarely they comminuted. But once again, we don't, that's kind of the nice thing about my job is we don't take call, ever. So there's no trauma or anything like that, at least right now, or there's nothing, because usually if something's very, very bad, they're going to go to the emergency room, they're going to get admitted and be having surgery. So we don't have that many comminuted patellar fractures in our practice. Once again, make sure that their extensor mechanism is intact and can do a straight leg raise before you deem them to be non-operative. You can once again aspirate their hemarthrosis. Now, the hard part with this is the rule I told you before. We don't aspirate anything if they can't bend their knee to a 90-degree angle, right? Well, if they have a patella fracture, they're not going to bend their knee to a 90-degree angle. So this would be strictly for pain. If they say, look, my knee feels so tight it's fixing to burst, that's whenever we would drain that there in the clinic. Knee immobilizer, once again, brace for 4 to 6 weeks. slow progressive range of motion with physical therapy. So what we will do with them is we'll put them in one of those flexion extension braces, which once again, if you guys haven't ever been hurt with your knee before, but it basically has numbers on the top and numbers on the bottom, and you can actually dictate how much they can bend and straighten their knee. So you can have them bend it to 10 degrees, to 20 degrees, to 30, and then it starts going up after that. So what we usually do with our patellar fractures, as well as quad tendon injuries and things like that, is we will give them 0 to 20 for the first 2 weeks, 0 to 40 for the second 2 weeks, 0 to 60 for the third 2 weeks, and then 0 to open all the way until 8. And then at 8 weeks, we will let them start putting their weight on it. But what we'll do is we'll always guarantee that when they're up, moving around, they go back to 0 to 20. Because if you think about it, if you have a broken patella, and I have you at 0 to 60 and you fall again, well, that means you get to move your knee back to this, right? So what we'll do is we'll teach them or their spouse, this is how you do passive range of motion, but at 0 to 60, so that way the brace stops them from going too far back. And their spouse, we call it the basket, and they'll just sit there and go up and down with their knee. That way they're getting passive range of motion and not hurting their patella in the meantime, and then you won't get a stiff knee. But if they're up moving around, they go automatically back to 0 to 20. That way if they fall, they can't bend it back so far they hurt themselves. Obviously quadriceps strengthening on that. Operative candidates, the extensor tendon or extensor mechanism is disrupted in any way, so if they cannot perform a straight leg raise. Displacement of a transverse fracture, so if it looks like that one, that piece is never coming home. So you might as well help them out with it. Displacement, comminution, articular step off, and that's the biggest thing, because a lot of times when people see fractures, and there's not a picture of them, but sometimes you'll just have a fracture right up here on the front part, or even if it's a transverse fracture, you don't care how the front looks, you care how the articular surface looks, because remember, that articular surface is the one that has a relationship with the femur. So if there's once again a step off like this, and now I'm bending and straightening my knee, that's not going to go very well. So it doesn't really matter how the front part looks as long as the articular surface is well maintained. And once again, it's a 2 millimeter step off. Compromised skin over the lining patella due to trauma. So once again, if you have that person who did fall off the porch and land directly on their kneecap and it's an open fracture, once again, there's not a lot of padding on the anterior aspect of your kneecap, so that would be another surgical candidate. Okay, we're getting there almost. Okay, so a knee dislocation. Once again, these are very, very rare, but this is a, I don't know if it's a board's question or not, but it probably should be. This is a big deal. If your knee is dislocated, and believe me, probably 10% of the people I see each month will come in and say, I dislocated my knee, but they're really talking about their kneecap. Everybody says, I dislocated my knee, but once again, that's automatically thinking about their kneecap, because if they dislocate their knee, they're not going to be walking in your office. Literally, the last lady that we fixed her knee on this, her boyfriend stole her car, and she went out and jumped on the hood of it like on the movies, and was holding on to the hood, and he was doing the whole swerve thing, and she was not a very, she wasn't a very limber or small person, and so the more that her weight started going back and forth, and eventually he just slung her off, and she literally dislocated her knee. The femur and the tibia were not anywhere close to each other. So laceration of the popliteal artery is the biggest ill and/or vein. This is a true medical emergency. If you see somebody dislocate their knee, you get them to the emergency room, because if not, they can actually lose the bottom half of their leg. Multi-ligament injury due to high-energy trauma. Once again, these are huge car accidents, stuff like that. Often both your ACL and your PCL, because you have to remember, your ACL keeps your tibia from sliding forward, right? Your PCL keeps it from going backwards, but you can imagine that both of them would still have to tear to get it out there like that. And usually one of your MCL, LCL. I have never seen all four. Have you, Dr. McNeil?
Never have.
Okay, so both of these and one of these. Classic case. Once again, these are not common. So what does the x-ray look like? That. Now you can imagine, and it doesn't take a whole lot of common sense, but you can imagine that if your ACL and your PCL are right here and they ended up over here, there's no doubt those are gone, right? I mean, just by looking at this. MCL, I guess if it came over and kind of went forward with it, but that's why this is a huge, huge deal. And then the last one is patellar subluxation. So once again, that happens, get them stabilized however you can, knee immobilizer, and then call the ambulance type deal. So patellar subluxation dislocation. So my funny story about this was my first job after I moved back from Las Vegas in sports medicine was to cover the Luther Lions. Does anybody know where Luther is? Way out there in the middle of nowhere. And so I got with our athletic trainer and said, okay, what do I need to have, you know, on me in my pocket and stuff like that. I had all the knowledge, as you guys now will, but then when you get out there, it kind of gets, you know, you get in a frenzy when people start getting hurt. And so my first patellar subluxation dislocation, so one of the things that the trainer said is, look, football players get nosebleeds all the time. Best thing for a nosebleed is a tampon, right? So I stuffed my pockets full of tampons. I mean, it's full, you know, it's winter. I mean, it's football season, so it's cold, so I've got a coat on. And I'm not kidding, I probably have 50 tampons in my pocket. I thought everybody on both teams were going to get nosebleeds this one night. And so this guy's out there rolling around on the ground and all this stuff. And so I forgot to zip my pocket. So I go out in the middle of the field, and you know, you kind of jog because you're freaking out and your adrenaline's going. And every step I took, it was like I was fertilizing the field with tampons. And then I get out there, and I loved Luther because people out there are not afraid to say how they're feeling. So I bend down, as soon as I bend down, the rest of them just fall out. And the referee goes, what the hell, man? And I went, oh, and I just turned around, and there was a whole trail of tampons. That's my patellar subluxation dislocation. So once again, patellar subluxation, it always goes lateral, right? Hardly ever medial. You never see somebody that says, my kneecap came over here. They'll come in, it'll be on the side of their leg. If you are for sure that they do not have a fracture, the easiest way to reduce a dislocated kneecap is straighten out their knee. You have to get them relaxed, but if you can passively and gently, don't yank it, but just gently straighten out their knee for them. So once again, medial patellofemoral ligament, medial patellar retinaculum, chondral surfaces. So whenever, it's what's saying, for this to happen, one of these three structures must fail. Usually when you get an MRI on a patellar dislocation, it will say a tear of the medial patellar retinaculum. That one is almost, I cannot remember the last time I've seen a patellar dislocation that they did not tear this unless they just had an amazing amount of ligamentous laxity. Most common in adolescents populations, more common than males or females and males. And an anatomic variant. So this is what your MRI will say on a patellar dislocation. Usually these. So hypoplastic femoral trochlea means what? Your trochlea is a valley, right? And your kneecap lives in it. If they're born in a way that their femoral trochlea is more shallow, imagine you being in a ditch. If the walls of that ditch are high, it's going to be harder for you to get out of that. If they're shallow, you can just walk right out. So if they have a hypoplastic femoral trochlea, that automatically sets them up because there's no wall for that kneecap to hit. Patella alta, as we all know, means more up above. So you remember in cadaveric anatomy when you looked at the femur, you looked at the trochlea, and the more north you went, the more proximal you went, what did it do? It got more shallow and more shallow and more shallow, right? So she's still laughing about the tampon. It's okay, we're all adults. But what happens is you can imagine if your kneecap sits higher on your femur, it's more shallow already. So now not only do you have a more shallow trochlea, now your kneecap's already higher up on the shallow part, so it's like a double whammy, right? And then a lateralized tibial tubercle, so you know your patellar tendon goes down to your tibial tubercle. If it starts off lateralized, it's already pushing your kneecap in this direction on top of those two things. So usually hypoplastic femoral trochlea, patella alta, and medial patellar retinaculum tear are your three MRI findings that you will see a lot of the time on the patellar subluxation dislocation. And also a contusion of the patella, right? So where your kneecap comes out over that femoral condyle, it'll hit it on the way out, kind of like a Hill-Sachs lesion, but in your knee. Presentation and acute dislocation, obviously, and this is kind of smart, but it's not. I mean, their kneecap will be on the side of their leg. It's not a whole lot of guesswork. You go, hey, there's a bump over here that's supposed to be here. That means their kneecap is dislocated. Often in the flexed position, and that's the hard part because whenever they dislocate it, they will be rolling around on the ground like this, and you come up and you say, hey, my name's Travis, nice to meet you, I'm going to take good care of you, I just need you to relax, I'm going to straighten out your leg, and they'll look at you like, you're going to, what? No, that's going to hurt real bad, and that's what I'm saying. If you can get them to relax enough and just gently straighten out their knee, it will bring it right back in, and they will thank you for it. Sublux, does everybody know the difference between subluxation and dislocation? So sublux means, or do I have any no's out there? I didn't see.
I don't know.
Okay, so and this goes for kneecaps, shoulders, whatever. So on a knee, let's do it on a shoulder because it's a little bit easier, but a subluxation is where, if remember the ball and socket of your shoulder, so a subluxation is where it kind of perches itself right up on the rim. So if you imagine the ball trying to get out of a bowl and sitting up on the side of a bowl, that and then it falls back in. That is a subluxation. A dislocation is it comes all the way out of the hole, or the ball, or the bowl. The hard part is whenever people have a subluxation, it will come up almost all the way out and fall back in, and they will swear to God that it dislocated because what did they feel? They felt it, I swear it went back in. Yeah, I was out, I couldn't move my shoulder, and all of a sudden it clunked back in. Well, that's it. Remember we talked about last time, how many people reduced their own first time or primary shoulder dislocations? Hardly any, right? Because it wasn't supposed to be out in the first place. So once again, subluxation, and what they'll do with on their kneecap is they'll say, well, it just kind of feels like it goes to the outside and then I'll feel it pop back in. A dislocation, it is on the side of their leg. That is very, very easy to see for everybody. But a subluxation, they will tell you that they felt it pop back in because it did pop back in. Reduced dislocation, once again, does everybody know where your medial patellar retinaculum is? So what you got to do on these guys is just push right there. And as soon as you start pushing that and doing that patellar apprehension test, they'll tell you a bunch of times that that's usually your diagnosis. Medialized knee pain, painful range of motion, inability to perform a straight leg raise often. So if all of this is very angry and they try to do it a lot of times, it'll hurt them over that medial side. Once again, a reduction, pressure applied to the patella in a medial direction, as well as brought back into extension. But you have to kind of tell them what, this is one of those ones that you tell them what you're going to do, because if you don't, they're going to be really, really mad, especially if you can't get it reduced. I've only done it twice, but it really does help them feel better. And as soon as you get them extended, put them in something that keeps their leg straight because you don't want to bend it again. Should be reduced ASAP for patient, once again, comfort and apprehension. All right. Examination. So once again, the apprehension test, as you can see, he's pushing their knee laterally. Palpation of the femoral attachment of the medial patellofemoral ligament, medial patellar retinaculum. And presence of mechanical symptoms during passive range of motion. So remember, if that kneecap is not living right in that valley as it should be, it's not going to be sliding up and down like it should be. So it's going to be hanging up more on the side, so you'll get some grinding and crepitus and things like that sometimes. Or it just doesn't feel right. They'll say, hey, it doesn't feel like my knee's in the middle. It feels like my knee's out. AP and lateral views, once again, Sunrise Rosenberg. So you can see, once again, there's that, how that's happening. So, and even if this, you see how the patella here, see how that's kind of more of a uphill right here, and this is kind of shallow, so you can almost see how it makes it easier for that to come out. Treatment conservative. So what happens is, and no loose body on the x-rays, of course. I think it could happen, but I don't know that I've ever seen it. Your medial patellar retinaculum, I guess, in theory, could pull off a piece of your patella if you were to dislocate it. Usually it's a bruise of that patella. You brace them in full extension, and for the first 3 weeks, you do not let them take that thing off for the first 3 weeks because you want everything to heal back in just like it is, but I'll still get MRIs on them. And then what we do is after that, so they're braced in full extension for the first 3 weeks, then after that we have something called a Healy-Weber brace. I don't know if you guys are familiar with those. Some people will call them a patellar J brace, but it's just a knee brace, and it has a little foam C over here, and you put it on the lateral side so that it always reminds their body that their kneecap needs to stay in. So it's almost like if their kneecap tries to come lateral, it hits this little bumper right there, and then you put them in therapy after 3 weeks. Usually this is about a 6 to 8 week type thing. Surgical is almost always chronic. Chronic dislocation multiple times. Loose body on the x-ray, of course, but once again, it's pretty rare. So back to this real fast. So what you say, okay, what's the surgical repair for something like this? So the one thing we can do is called a lateral release. So if you think about it, I always tell people that, you know, your quadriceps and your lower leg keep your kneecap moving up and down like they're supposed to, but there's not a lot that keeps it going side to side. So I always tell people there's kind of that piece of saran wrap, your patellar retinaculum, and so you can imagine if this part is too tight, this part has now been torn. Well, if we go over and release this side, it lets everything center back up. So that's what you're doing when you hear a lateral release. The other one is whenever you've done all that in therapy and all that, and it's called a Fulkerson's osteotomy. Have you guys ever heard of that at all? So a Fulkerson osteotomy is a big, huge deal, and they're not very common, but we still do them. Is whenever, so remember we talked about a lateral attachment of their patellar tendon, so instead of being straight up and down, you can imagine if my patellar tendon goes over here like this, it's automatically going to want to make my kneecap go laterally, right? So what we do is we literally cut this piece of bone where their patellar tendon is attached, and we medialize it. We scoot it over some, so it brings the whole patellar quadricep mechanism medialized. It's called a Fulkerson's osteotomy, and that is a 9-month rehab. It takes forever to get over that, but they have a very, very small chance of dislocating after that. But they don't want to ever do anything again, obviously, just because they had to go through all that surgery. Okay, patellofemoral joint. This is what I think the young lady in the striped dress was talking about early. Patellofemoral joint in the Q angle, and this kind of gets into that. Patellar tendon rupture, actually kind of common. Flexor extension, or failure of the extensor mechanism due to excessive loading on unhealthy soft tissue. So people who've had like chronic patellar tendonitis, things like that, usually happens in people like me, kind of middle-aged people who are trying to stay in shape and then fall down. Also, or try to do squats or lunges or stuff like that. Also included the quadriceps. Speaking of that, has anybody done Orange Theory here? At all, the workout place? You have? Okay, I've got a funny story about Orange Theory. So Orange Theory, this is kind of comical. The Orange Theory is that you get on this treadmill and you wear this heart rate monitor, right? Correct me if I'm wrong. And they monitor your heart rate and all this stuff. So the first 30 minutes are cardio, the second 30 minutes are weightlifting and all that. Well, I tried it last Sunday, and the lady was like, wow, you're in really good shape, because I'm going on the treadmill and all that stuff, and the trainer goes, you're in really good shape. And I was like, no, that's why I'm here. I'm not in good shape. And she said, no, you need to keep going. So she keeps telling me to go faster and faster. I don't know about you guys on a treadmill, but running for me is like 6 miles an hour. That's pretty good for me, probably about a 70% or whatnot. So she goes, you gotta keep going higher and higher and higher. So I'm up at like 8.59, which to me, I don't know if you guys are old enough to watch Friends, but when Phoebe tries to teach people how to run, the Phoebe run, so I'm Phoebe running on the treadmill. And this takes her 29 minutes to recognize, but I've already ran 3.5 miles. I've never run over 2 miles in my life, like ever. And I'm at 2.5, 3 miles, and the lady comes up and she goes, your heart rate thing's not working. Okay, so the whole time I've been trying to get my heart rate up and just running myself silly. And she goes, well, we've got to go to the weightlifting now. And I'm not kidding, by the end of the weightlifting, there are all these people that are in their 60s and 50s are in there high-five and talking about what they ate after church. And I'm laying face down on the ground, like arms to my side like this, and I could not breathe. I thought I was going to have a heart attack and all that. So be careful when you go to Orange Theory. Make sure your heart rate monitor works. So that's where it gets into middle-aged patients trying to stay in shape. I was so mad at them. And then they wanted me to join up. And the lady literally, I was laying face down, and she came down and laid the clipboard down by me. She was like, sir, these are our prices. And I was just like, I'm not talking to you anymore. So, 48-year-old male presumes to the emergency room, onset of acute knee pain, once again unable to perform a straight leg raise. That's why I had him do that the very first thing. If you can't do a straight leg raise, that means there's something wrong with your quad tendon, your patella, or your patellar tendon straight off the bat. Difficulty with full weight bearing and ambulation due to extensor mechanism. Significant soft tissue edema and ecchymosis. These things will swell up and bruise up very quickly. Once again, inability to perform a straight leg raise gives you a clue of there's something going on. Because remember, your extensor mechanism is the quad tendon, the patellar tendon, and your tibia, right? It's like a crane. It's like a motor that pulls the cable. So if they can't do that, you need to automatically start thinking about why they can't do that. Palpable visible defect. A lot of these patellar tendon ruptures, you can put your thumb in them. So remember how whenever he was laid up there and I pushed my thumb on him, and you can feel it, it's taut. If they tear that, just like an Achilles tendon, your thumb will just sink in if it's a full thickness tear. Let's see here. AP and laterals, so see this. So obviously, remember, it's a whole mechanism, so this is coming down. So if this big, huge muscle, your quad, is still attached and you tear that, it's going to pull it proximally. AP and lateral radiographs, you already know what it is. MRI, just to be helpful in a partial rupture. So if they don't have a soft spot, but then they still can't do a straight leg raise and all of that, that's where you have to be suspicious. Especially if it was acute injury. Usually, patellar tendonitis is usually your runners, your pole vaulters, your basketball players, jumpers knee, that type of deal. But they're still able to play sports. These people will come in going, I was playing sports and I felt something and I haven't touched the field since. And that's where you have to worry about it. Treatment, referral to a surgical consultation. All surgical injuries, you cannot obviously tell this guy right here, well, your kneecap's going to be a little bit higher, but let's just see how you do with it. You go in and you fix that. Osgood-Schlatters disease, does everybody know about this? Is everybody pretty familiar with it? Want me to go through it with you? Basically, the biggest thing on this, and the one place that you can get fooled on this, is always ask about trauma. Because Whenever you look at this right here, if my finger will work correctly, right here, you would just go, oh yeah, it's Osgood-Schlatter's disease, they have pain over it. But remember, with Osgood-Schlatter's disease, a lot of time they will have tenderness over their patellar tendon, but if they have trauma, like I got hit with a baseball or a bat, or I fell down on my knee, and they have tenderness over that, you cannot prove that that's not a Salter-Harris 1 fracture of their tibia, right? Because it's an open growth plate. Remember last time we talked about that? Tenderness palpation over an open growth plate is a fracture until proven otherwise. So if they just come in and say, yeah, I'm a pole vaulter, and man, my knee's just been getting more sore, and my friends don't have bumps on the front of their knee, but my knee does, okay, now we're talking Osgood-Schlatter's, right? But if they say, no, I got hit with something, or I fell, and they won't let you touch that bone, you need to immobilize them and potentially even get an MRI to prove that they don't have a fracture through their growth plate there. Painful anterior knee, most likely males. This one is different because they'll have anterior knee pain, but they can still do their knee raise, straight leg raise, right? Because why? They still have their extensor mechanism intact. There's nothing wrong with their tendons, it's just the bone right there, or patellar tendonitis. A traumatic overuse injury versus an all of a sudden, and they will not kneel down on it. They'll say, man, I don't know what it is, like especially our wrestlers that get this. I can't kneel down, I can't get down into that, or like a football player getting down to 4-point stance, something like that. This is definitely a clinical diagnosis, and in medicine, or especially in orthopedics, we call it pain versus harm. Because you know, little Billy, once again, is the next Nolan Ryan or whatever. And Dad's like, hey, how can I know if we can do this or not? This is truly, once you've ruled out any kind of a fracture or a Salter-Harris fracture, it is pain versus harm. Harm means if you keep going, you're going to injure yourself. Pain means if you can do it without limping, we don't mind if you go do that. Some anti-inflammatories and all that. Once again, avulsion and or fragmentation of the apophysis. Those were whenever we would need to do something, but once again, very, very rare on that. See, this is the fragmentation right there. See that one right, I don't know if you can see it, sorry. But see how this one's no longer connecting anything, so that could have even been an old avulsion that as long as it's not tender over that, we still wouldn't do anything with that. Once again, reassurance of mom and dad by far more than the kids. Modify the activity, Rice protocol, and go from there. Last one, I believe. Chondromalacia patella is basically the fissuring of the articular surface behind the kneecap. Once again, these people will come in saying, look, every time I stand up after being seated for long periods of time, things like that, I feel this grinding behind my knee. It doesn't bother them at first, but the more I go up and down stairs, the more it hurts. Once again, crepitus increases with active range of motion, specifically if you have them resisted. So if I'm sitting in a chair and I have them extend their knee, it will act, and you have your one hand on their kneecap and the other one's resisting their extension, it actually accentuates it. It'll make the grinding worse because it's sucking their kneecap back down into that trochlea. Painful squatting, duck walk, similar to a meniscal tear, but no medial or lateral joint line pain. And they also don't have any tenderness palpation. These guys don't hurt unless they're going up and down stairs, stuff like that. Imaging, you usually can't see it because remember, you can't see the articular cartilage so much on the x-rays. So once again, patella alta is too high, baja is too low, and then lateralization you can only see with the sunrise view. Conservative treatment, Rice, anti-inflammatories, sometimes steroid injections, and a lot of times on these, if they're a certain age, we'll actually start doing the Hyalgin injections or the viscosupplementation, because if you have a piece of rough stuff and a piece of rough stuff and they're rubbing on each other, what better to do than to lubricate that, right? And that's why we do the Hyalgin or the Orthovisc injections. Surgical is very, very rare on these because a lot of times if they're kneecaps like that, the rest of their knee will sometimes be as well, and then you would fix it with a total knee replacement. This right here, shaving chondroplasty articular surface, so let's get this one just out there. So when somebody comes to you and said, I had surgery and my doctor cleaned out my arthritis, is that even physically possible? No? Anybody think it can be? So this is what's hardest whenever they've seen another orthopedic surgeon, and a lot of people say it just because it's easier than explaining it, is yeah, the doctor went in, I had a medial meniscal tear, he fixed that, but then he also took out the arthritis. So when they come see me and I take x-rays, I'll say, well, we see that you have some medial joint line arthritis. No, my doctor cleaned all of that out of there. Well, no, you can't really do that. So I make for sure that whenever I see everybody 1 week post-op, no matter what surgery it is, I see everybody 1 week post-op, and I will say it's more almost like a polishing. We can't stop it, or otherwise nobody would ever have to have a total knee replacement. We would just keep going in and cleaning it out. So this one's kind of, it doesn't work. It is called a chondroplasty, but that's more for temporary relief and to kind of keep it from continuing to fray out, but you cannot clean out arthritis. Plica syndrome, that one. So the plica, this one just as a quick note, a plica is it will fool you time and time again. A plica mimics a medial meniscal tear almost all of the time. So here's what we do for plicas. Let's say you have a soccer, and this one actually happened. We had a soccer player from Moore. Came in, I'm a soccer player, outdoor, I was cutting and pivoting, and I feel this popping on the medial aspect of my knee. Okay, well, and I'll give them my 5 options, same thing for the shoulder. Well, of course, they're the next Pele, so they want an MRI. So we go get an MRI, and it comes back normal. Well, that kind of is weird. I swore she had a meniscal tear. So anytime that you think somebody has a medial meniscal tear, and they come back with a normal MRI, your little beeper should go up for a plica. Does everybody know what a plica is? So in your capsule, your joint capsule of your knee, right, it's your capsule. So a plica is on the medial aspect right over here, and it's a little redundant piece of tissue. Has anybody ever made a pie before? Right, so when you lay the crust over the top, you trim off the sides, right, because it's hanging over. It's just like that, but it's folded inside. It's a little ridge on the inside that can rub up against stuff. So what our treatment plan is if, once again, I think you have a medial meniscal tear and you're a young athlete, what we will do is we will inject their knee, regardless of age. I mean, not like a 5-year-old or anything, but if they're playing sports, I'll inject their knee with a steroid injection, because with a normal MRI that plicas cannot be seen on, if I inject their knee with lidocaine steroid and their symptoms go away for an hour, a day, an hour, 3 hours, whatever, if it goes away and then comes back as soon as the shot wears off, that's almost a that makes you very, very suspicious for a plica, because you will not see a plica on MRI 99% of the time. So if you do that, and what I'll do as a PA is I'll say, look, I'm going to inject your knee today. You're going to come back with 3 answers. One answer is, hey, the shot worked. I'm still great. Thanks for everything. See you later. Bye. Second thing is, I came back and man, my pain went away, but as soon as that shot wore off, those same mechanical symptoms and that same pain came back. Well, that's suspicious. And if it didn't work at all, you still would probably do it. So what we would do with those last 2 patients is we would do a diagnostic arthroscopy on them, because we know that there's nothing wrong that we can see from an MRI, but they're having mechanical symptoms like a medial meniscal tear. Just tuck that one away. That one will save you some time. Osteoarthritis of the knee. You guys have probably seen this before. Important to address causation and location. Chronic degeneration of the articular cartilage. Medial femoral condyle and medial tibial plateau by far the most common. Lateral and then patellofemoral. Lateral is probably the least. Patellofemoral and medial is by far the most common. So whenever you look at somebody's knee, of course your femur, kneecap, tibia, fibula. And so if we all just went out and grabbed a bunch of people and started x-raying them over the age of 50, 60, most of them would have medial joint line narrowing. So if this space is more narrow than this space, then that is medial joint line narrowing, right? Post-surgical changes, if they had a meniscal tear that we know that can accelerate osteoarthritis, that could happen. Non-operative management of a ligamentous injury, once again, they had an ACL tear, didn't fix it, we all know that that can cause it. Or a fracture, so if they had a bad step off and didn't get it fixed, all of those reasons that they can get osteoarthritic changes. This one, I don't know, sorry about that, it went over there, but non-operative treatment are all the stuff that you guys know. Anti-inflammatories, icing anti-inflammatories. Corticosteroids, you have to be kind of careful with that, because if you have osteoarthritis, it's the mechanical symptoms that are bothering you. So we'll do one for osteoarthritis, but we'll really only do one, because if not, you're just kind of putting a Band-Aid on it. And we'll do high hyaluronic acid or the viscosupplementation, which is once again like Hyalgan and Orthovisc and things like that. That is basically an artificial buffer, right? And we just put it in there. It doesn't change the fact that they have arthritis. It doesn't regrow their articular cartilage, but it is going to go in there. It's like greasing a rusty joint is the best way I can tell you about it. Now, one thing that I didn't get to put on this side, or I actually did, but I had already emailed this one to Amber, is something that we do in our office, and it's getting, we do these things called biologics. Has anybody ever heard of PRP, amniotic fluid, stuff like that? So we have 3 options after steroid injections and hyaluronic acid injections. Number one is called PRP. PRP, we draw their blood from them, spin it down to the plasma that's rich in platelets and interleukins and things like that, and we actually inject that back into their joint. Anytime you're dealing with biological stuff, no insurance company covers them, and it's very, very expensive. That one shot, and you only need one usually, but that one shot is $400 straight out of your pocket cash right there. The second one we use is called amniotic allograft. So amniotic fluid, baby inside a mama. They get the amniotic fluid, which is sterile. They've been using it in the eyes for like 20 years and had no problems with it whatsoever. But once again, interleukins, tissue growth factors, all of that stuff. And believe it or not, we've probably done 70 of those. And I would tell you that probably 65 people would pay the money again. Those are $2,000 a shot, and believe it or not, that's cheap. If you go to Dallas or the coast, you're looking at anywhere between $8,000 and $10,000 for one shot that there's a 50-50 chance that you'll get better with. In our practice, it's way better than a 50-50 chance. Like I said, 5 out of 70 is not bad. I'll take those odds in Vegas any day. The last thing we do is called stem cells. You guys have probably heard of those. And a lot of times you have to be careful when you're talking to people about these, because they will lump PRP, amniotic allograft, prolotherapy, and stem cells all in the same thing, and it's not the same thing. The stem cell injections, there's two ways to get them. One is you go to their ASIS in the operating room and you core out a piece of their bone, spin it down, get the stem cells, and then inject that back into their knee. That is the grand poobah of them all. If any of them are going to work, that's got the best chance. That is $8,000 per shot, straight out of your pocket on a check. Thank you very much. Let's go to surgery type deal. And that's not including the surgical fees. That is just the act of doing it and having the machinery there to spin it down. The second way of doing it, they're actually coming up with it. I don't know that it's hit mainstream yet, but they're also doing it. They can do it by taking your abdominal fat, almost like a liposuction, because there's stem cells in your fat. And whenever you disrupt them with a liposuction type technique, you can. Some people are even doing those in the office. Believe it or not, we're not. It's not to Oklahoma yet, as far as I know. So once again, for osteoarthritis, so there is other things out there. When people come in and say, "I've had 5 steroid shots. I've already tried the series of shots. What else is there out there?" There are other things out there. Physical therapy bracing. The bracing for these is called a medial unloader brace, and believe it or not, it is literally a brace that puts pressure. Remember, most people have osteoarthritis here, right? So it puts pressure on the medial side of their joint, on the one place that hurts the most. So I will tell you that most people do not enjoy wearing those. There's usually 1 out of 10 that will say it's the best thing ever, but everybody else have the new, $300 to $400 paperweight that sits in their closet. An activity modification, common sense. Surgical management is an arthroplasty, which is what this looks like. This is an AP, so you can see the femoral component, the tibial component, and there's a very hard piece of plastic in between the two called a polyethylene that mimics the meniscus. Okay, so I know this one's been a little bit longer than the shoulder, I promise. I'm sorry. So always compare bilaterally, do the special test, x-rays if necessary. A fusion never lies intra-articular pathology. Remember, our knee is inside of a water balloon. If that water balloon is swollen, something had to happen to make it get that way. So always look for the reason. Acute injury plus a fusion, I felt a hurt and pop, you're thinking ACL, right? Okay, and then make sure you get their history. Once again, if I come in and I say, "Hey, I'm a basketball player, I went to do this and I twisted and went this way and it hurts when I turn left," you're automatically thinking medial meniscus, right? So, you guys are already saying this, and we've only been talking for like an hour and 20 or 40 minutes. But the point is these things will get so repetitive. Believe me, by the 16th year, you'll go in there and you'll go, "Your meniscus is a rubber shock absorber." It's almost like you're giving a guided tour. You just kind of go into robot mode and start talking about these things. Real quick, 14-year-old male accused to the ER, playing flag football, struck on the lateral aspect of his knee, felt hurt pop, difficulty bearing weight. All right. Large joint effusion, all medially. Ligament exam reels grade 3, laxity of the MCL, grade 2 of the ACL, negative patellar apprehension. And I think that is it. Okay. Any questions or concerns? That kind of ended abruptly, though, didn't it? Injury, anyway, ACL, MCL, but always check for their meniscus and then go get an MRI. Anything else? Everybody good?
Would you aspirate for culture and sensitivity on a septic list?
Yes, so whenever I said before, we always aspirate what? Things we're worried about being infected. The only other thing that we aspirate is if they can't get to 9 degrees, the only other thing we'd aspirate is if you had a total knee replacement and we were worried about hardware loosening. So we would aspirate you, we would send you down to the laboratory for blood work, and we would get a whole body bone scan, because those are the 3 3. That's kind of the triad for a loose total joint, because you can't see it sometimes on the x-ray. So on a patella, or either a lecture non-precise, which by far is the most common to get infected, we would aspirate it, send them down, but we would also get their blood work as well. And then and we do it on a stat basis, and if that comes in, I tell them, hey, I'm gonna draw this fluid, you're gonna go to the lab, and you're gonna go home, and you cannot eat or drink anything, because if it is that, you usually have to go to surgery that day. That's one that you don't play around with, because once again, if it seeds the joint, it's infected, and then they've got a septic joint, and now they're staying in the hospital versus going home that night. Okay, it's been a pleasure, you guys.
Thank
Thank
you.
you for listening.